Okay. Well, thank you all for being here and for joining us. Welcome to this session of the 2024 Culture of Data Conference. My name is Anne Hill. My pronouns are she, her, hers, and I will be moderating this session. We also have Sudev. Those are my dogs too. Sudev is going to be managing the Zoom and making sure the tech is running smoothly. Right now, you're all muted, but if you have a question during the Q&A sessions, please feel free to unmute in the Q&A session that's usually held at the end. You can also use the chat box if you have any questions or you need to ask anything during this time. If you're comfortable doing so, we do ask right now that you add your pronouns to your Zoom name, and you can do so by clicking the three dots on your video square and selecting Rename. We have just one presentation during this session. The presenter will probably go for 25 minutes or less, but then afterwards we'll have about 10 minutes for question and answers. This presentation that we will be listening to describes the opportunity for Adams County Health Department's epidemiology and data science team to collaborate with the harm reduction team as well as CDPHE, the Colorado Department of Public Health and Environment, to modernize data processes. I'm now going to turn it over to Mallory Houston to present Digitizing Wellness, Advancing Harm Reduction Through Data Innovation. Mallory, take it away.
I'm sorry. Yeah, let's see. Oh, sorry. I need to share my screen.
Sudev, could you remove the welcome slide?
Yes, I am doing that right now. You should be able to share your screen now, Mallory.
Great. Okay, thank you. Can everyone see okay?
Not yet.
Not yet.
No? Okay. Let's see. Let's try this again. How about now?
Looks good.
Looks good? Okay. Just wanted to make sure. Okay, great. Oops. Sorry. One moment. Okay. Sorry about this. Okay. All right. So thank you for everyone for coming and for your patience in the very beginning. My name is Mallory Houston. I am a population health epidemiologist at the Adams County Health Department in Colorado. So I am going to present to you my lecture on digitalizing wellness. This is advancing harm reduction through data innovation. So first, I just want to go over the agenda. So I'm going to go over the introduction and overview of this project and why it was necessary and what we wanted to accomplish from it. Then I'm going to talk about the initial state and the ideal state, so how things were before we did this data modernization project and how we wanted them to turn out afterwards. And then I'll talk about the collaborative efforts and methodology that were necessary in order to build this project. And then I'll show you some screenshots of the finalized state. And I'll talk about some challenges and lessons learned and some key milestones and benefits that came from this project. And then we'll have time for the Q&A session. So first off, I'm just going to give a quick introduction on the Adams County Health Department. So there are 6 divisions, and I work for this epidemiology and data science one. And within the epidemiology and data science division, I work for this particular program, the population health epidemiology /data program. And you see here is a map of Adams County. So we have 10 municipalities, mainly kept in the more western part of the county. And over here on the eastern part is where we have much more rural, a much more rural portion, and there's several unincorporated territories here. All right, so for the project overview, so the point of this project is that we wanted to help the harm reduction program. They are part of the public health nursing division in the Adams County Health Department, and we were also going to collaborate, or we also needed to collaborate with the Colorado Department of Public Health and Environment, otherwise known as the CDPHE, in order to complete this project successfully. And so the purpose of this was to enhance efficiency in the harm reduction team's paperwork and data upload process, to eliminate redundant data entry, thereby enabling more time for client interactions. So with this data modernization project, we had 4 top priorities. You can see that they were converting client-facing forms to digital forms, of which there were 8. We wanted to eliminate double and triple data entry that the harm reduction team would have to do. We wanted to create an internal client lookup tool for more streamlined data search processes. And then we wanted to be able to upload data directly into CDPHE's REDCap database. So first, this is just a diagram of what the initial state looked like, that is before the data modernization process happened. And so you can see here that purple is just talking about the client types, of which there could either be a new client or an existing client. Then the orange are the client paper forms, which needed to be uploaded into REDCap. And then the green stands for ACHD, or Adams County Health Department staff specific forms, again used for internal tracking. So basically what would happen is that a new client would come in, fill out a consent form, and then depending on what the client needed, they would either go to the HIV, HCV, or STI testing program, or they could go to the Syringe access program, or they could also do both. And so again, depending on what the client needed, so they could get different sort of testing, different resources given to them, and then depending on the interaction that they had with the client, then the staff would have to fill out encounter forms, distribution log to keep track of how many services were given out, how many resources were given out, and also a distribution log for the next naloxone and fentanyl test strips. And so the ideal state, so we have 8 forms that have, so our ideal state is that we have 8 forms that have been made digital, where client or staff are able to enter data from phone, tablet, or computer. And the thing that was very imperative is that we wanted to make it so that they could enter data out in the field with or without Wi-Fi, because the harm reduction team is not always within the office building when they're collecting this information from our clients, or from their clients. And the ideal state allows for the harm reduction team to look up clients and perform auto uploads of collected data from the digital form. Right. You can see here that this is a screenshot of what we had to do for field mapping. And so basically we started out, we had CDPHE's data dictionaries and labels, and then we had the harm reduction team's paper forms. So we had to match those up to make sure that the questions and variables went to the proper digital forms and the harm reductions forms. So basically what I'm saying is that, so you can see here the ACHD Survey 123. Survey 123 is what we used for data collection processes, just because we wanted something that, again, it was necessary to have something that would work with or without Wi-Fi. And so then so this is our survey 123, and then this is CDPHE's REDCap. And you can see here that we would have to make sure, okay, did something was a question related to the ACHD only? Was a question only in REDCap, or was there a match in both? And so we also, so when we were comparing the again, the data dictionary and the forms for what Survey 123 had versus what harm reduction team had versus what the CDPHE had, we were able to match up the question schema for how they are currently stored in REDCap, so that there wouldn't be any issues with with the data uploads. What I mean by the question schema was, is the question stored as a text? Is it a multiple choice question? That sort of thing. And we also had to make sure that all of the CDPHE's required questions were included. And another thing that I want to, again, just reiterate everything is why did we use Survey 123 instead of just keeping the REDCap process? We wanted a survey that allowed for data collection with or without Wi-Fi, and we also wanted to cut down on the amount of times that harm reduction team had to enter the data. So those were our two main reasons for using Survey 123 for data collection instead of REDCap. Okay, and so here are the 4 softwares that we used in the process of making this data modernization tool. And so you can see here that these top boxes are just sort of like a quick summary of what each software was used for. So basically, the Survey 123 allows for online and offline data collection processes. The ArcGIS Online, this one right here, is a cloud-based software that we use as a staging area to store data temporarily using HIPAA-compliant software. But we wanted this data to be extremely secure because this is very sensitive data that the harm reduction team was collecting. So then because of that, we used FME software as our ETL, as our which stands for extract, transfer, and load software. And so basically, what FME would do is it would as soon as a record was uploaded from Survey 123 onto ArcGIS Online, then it would immediately be pulled from ArcGIS Online by FME, written to the final storage place, which is our internal ArcGIS portal, and then it would then delete it from ArcGIS Online so that it was only stored now on this internal ArcGIS portal, which is actually just connected to our internal server, and it actually doesn't even have internet access. And so another reason why we wanted to use the Survey 123 is because it allowed us to be able to, we wanted our own, the reason why we wanted the ArcGIS portal is that we wanted to have a final storage place for our data, and we wanted to be able to then make dashboards and use KPIs related to the information, and so that way we could perform our own analytics by keeping it all in this internal ArcGIS portal, which again is attached to our server and is not attached to the cloud. And then our reasoning for using the portal instead of just keeping it on ArcGIS Online, even though ArcGIS Online is HIPAA compliant, is that we felt that there was less likely of a chance of someone inadvertently sharing PHI on our internal server, again, because it doesn't have internet access. Okay, so you can see here that this is a screenshot of the FME process, the ETL process that I mentioned earlier. And basically what happens is that the public-facing Survey 123 form gets submitted. So the data collection form gets submitted, triggering a webhook to run the automation. And so then the data gets pulled from ArcGIS Online, which again is that cloud-based software. And then you can see in this purple box right here that some of the fields are getting renamed or reformatted based on the CDPHE criteria. You can see in this white box that there are signatures getting stored into a secure folder on our network drive. You can see in the red box, this is showing the process of the records getting deleted from ArcGIS Online. Again, that is that cloud-based software. And then in the green box, that is showing the process of the records getting written to our secure internal database. Again, that's that ArcGIS portal, internal portal, which is, again, connected to our own server and not the cloud. Oops, sorry. And then this gray box here is just the process of the harm reduction team getting an email once a new record has been added. So the finalized state, so you can see a screenshot of some of the just what some of the survey forms look like that we created. So there are 7 public-facing digital forms, and these forms capture consent, HIV, STI or STI testing, and resource usage, and these sit in survey 1, 2, 3. Again, these are the data collection tools, so that's why they are in survey 1, 2, 3. And then you can see these forms. These are the internal surveys. These sit in the enterprise portal. Again, that's the thing that is connected to our own internal server. And these are the same surveys as the paper forms, but staff have editing capabilities to add client notes. Right, and so this is just a screenshot of what the final dashboard, the internal client lookup tool looks like within the dashboard. And so to start off with, I'm going to look at this first pink rectangle. And you can see here that this is just an overall summary of all of the forms that we have collected from all of that, so that harm reduction team has collected from all of their clients. So you can just get a really quick snapshot of the kind of forms that have been filled out already. And then now in this next, this second pink rectangle, this is, I mentioned before that we wanted to create a client lookup tool. Again, this both allows for a streamlined data search process, but it also allows for us to, for the harm reduction team to keep better track of any sort of existing clients. And so basically what happens is that if harm reduction team get someone, they can just type their name right here in the search bar, and then they can click on the name that comes up, and then they get all of the person's specific information related to any of the forms that they have, that the client themselves have, or the client or the staff have filled out on behalf of this client. And so here, the third rectangle, pink rectangle down here is, so these are all the forms that are specific, that would be then specific to the client themselves. Again, like up here is where we had an overall snapshot of the total amount of forms for the entire database. But here we can look at the specific forms for the client, and you can see here that we have a quick snapshot of the information, but we also have embedded the actual digital form itself, so that staff can look at that and see the full form. Great. So some challenges and lessons learned. Data mapping. So there was start with this one. Data mapping. There was a lot of back and forth with the harm reduction team and the CDPHE, who were really great partners and really just helped this process go, very smoothly. There was a lot of cross comparison that we had to do in terms of the data mapping, just making sure that the variables matched up the way that they needed to within each of the required sheets that the harm reduction team needed. So it was really great working with these two teams and entities. Let's see. Then next is this building interface. So this was very important because we had to be very cautious when making a public form, but then it had to be super secure on the back end. So basically, we wanted a way to collect data that was easily accessible to, again, to clients or to the harm reduction team themselves. But then we needed it so that it was just completely locked down and secure because, again, very sensitive information that is being collected, and so that's why we would kept it on our on the portal, which was connected to our internal server. Then also just some other things with building the interface is that there were some data schema issues, some issues transferring signatures, and then we had also just had the server go down one time, and then finally pilot testing. So we wanted user input because at the end of the day, the people who are actually going to be using this tool is not us, who the epidemiology and data science team who built the data monetization program, but it was actually the harm reduction team who was going to be using it. So we really wanted there was user input, and so it was very helpful because we were able to get a good idea of what the harm reduction team both wanted and needed. And so we got many edits from this, and so that's another thing that was that was definitely a lesson learned, and not even a lesson learned, but just something that was necessary for this project, is that it was a very much like a very iterative process where we would have to go through these steps like a few times in order to make a product that was really matching what the harm reduction team needed. All right. So the key milestones slash benefits. So the first one, and this one obviously was very important for the epidemiology and data science team, is that harm reduction loved it. So this was important because, like I said, they were the ones who were going to be using it, but they liked that it would just again streamline their processes, make it so they would not have to do double and triple data entry, and this, again, the end result of this is that the team can spend more time focusing on clients rather than data entry. This also allowed the harm reduction team to maintain client history internally. Again, so this is relating back to the client lookup tool, where again, it's just much easier to just group existing data together for existing clients, so that they're able to see what has happened with this previous client, and then they're also able to make any sort of notes on the client's file as needed for the harm reduction team. Then other things that allows for the this helped monitor the progress of the program. So this was helpful for KPIs, that's key performance indicators. Again, so this with this digital tool, it then made it easier for the harm reduction tool to keep track of how many clients are they seeing, how many resources are they giving out, which one of the two programs is the testing being used more often, the syringe access program, like which one is being, like how is it being used, so those were all very important things. And then some other benefits is that, again, because we have the Survey 123 and the ArcGIS portal the ArcGIS portal system, we are then able to store the data, and then we're able to make dashboards of it, analytics, and again, we're able to just track the progress of things much more smoothly. So that is it. Does anyone have any questions? And should I stop sharing my screen?
That depends on you. You're welcome to keep it up. We are now at the portion which there is an open Q&A. So we encourage you to unmute, but you're also welcome to put questions in the chat. Mallory, I can start. Number one, thank you for including those the efficiency measures that you were looking at. That was really neat that you were able to pilot test that. I was wondering how, and this is more of a preliminary question, but how are you able, or who's going to be dealing with like missing data or data errors?
Yeah, so that was part of why the editing process was important. So the dashboard allows for the staff to go in and make edits if they notice, for example, like was the patient's name put in wrong, or that sort of thing. So yeah, so we did have an editing capability.
Awesome, thank you. Other questions for Mallory?
So staff are able to also review the records.
Oh, nice. I guess an additional question I would have is, now that you've done this for the harm reduction portion, are you thinking of expanding your efforts across Adams County and doing this for other groups?
So this was I guess it really depends on if there's like if other programs request it, because this was something that harm reduction team very much needed. But if there yes, so it is one of those things where we would be happy to if there is a need for sure.
There is a question in the chat that I will read. Do you find any issues with duplicate, client records in the system? If so, how do you handle those?
Yes, okay, so that so we actually have a client specific ID that was part of the client lookup tool. And so it does allow for and that was actually one of the reasons why we wanted the client lookup tool, is because previously it was much harder for the harm reduction team to see if there were any sort of duplicates. But this again allows, because of the dashboard, because the data being pooled, or like the clients being pulled into like an easily searchable form, it's much easier for the harm reduction team to just see do these appear to be duplicate records.
Thank you. Are there any additional questions? Okay, I'm going to wait a bit, but I want to thank you all for attending this session and for also engaging in the Q&A. I just have a few announcements, and many of you have heard these before too, but the slides and the additional handouts will be available on Sketch. There will be a conference evaluation that comes out after this entire conference is over. It's going to come out by email, and we highly encourage you to fill it out and complete it, even if you've only attended a portion of the Culture of Data conference. It's really helpful in preparing for the next Culture of Data, and it'll help the planning committee as well. There will also be a raffle for those who complete it within the next 2 weeks, and you could win one of 2 $50 gift cards. This is the last session. It's the last live session, I should say, at the conference, but the content isn't done yet. There's one more walk and talk session, so take a walk or do something that's relaxing, and listen to the presentation titled Promoting Health Equity Through Program Evaluation Partnerships. After that, the conference will be officially over. We hope you've enjoyed everything, and we encourage you to check out Public Health in the Rockies, which is also a great event that's put on by the Colorado Public Health Association every single year. Thank you for supporting CPHA and joining us for these sessions, and we hope you had a great couple of days.